Thank you again for the introduction. So this morning I will present what we are doing. So this is we started in 2020 with our Spanish natural history study, and that we are continuing overlapping with the European natural history study. And we developed this GNAO1 severity score in 21 GNAO1 patient. And in 2023, we correlate these findings with the functional analysis made by Dr. Martemianov. And in this year, we have performed this video EEG biomarkers that I showed you yesterday, and also in the poster session, but I'm going to make some highlight again about this expert consensus and the parent survey on this kinetic crisis, and also the parent surveys on DBS decision making. And we reported 2 new variants linked to mild phenotypes. In this year, I will show you some preliminary results on brain MRI biomarkers also. We are continuing with the natural history study funded by the European Joint Program. And also we have described the functional analysis of a new variant that you can see over there. And for next year, we have started, but we are planning to finish next year our project on biomarkers based on MRI sequencing, and also to finish our project on the validation of GNAO1 severity score. So to start with the first part, that is the patient-centered approach with caregiver insight, we have these 2 projects that I presented yesterday that we consider very important, because this kinetic crisis is the main cause of death for GNAO1 patient. So we wanted to know the point of view from the caregivers, because when we perform our expert consensus, we realize that there are a lot of data that we cannot capture from the expert, and even cannot be captured by a natural history study. These include retrospective data, and also to understand how if there are new triggers, the frequency, and also the impact of this kinetic crisis. And this is with the aim to provide a better support, education, and also to find new therapeutic approach for affected family. So in this kinetic crisis that participate 26 parents, they report that crises vary in each children. Some of these children don't have any dyskinetic crisis. When they have around, this is the median, it's 2 or 3 times monthly, but we know that there are some patients that have a daily dyskinetic crisis. The duration can be from minutes, in even seconds, to 1 or more hours, and they are usually triggered by stress or fatigue. As I showed you yesterday, more than 3/4 of these parents noted that there is a severe overall impact of this dyskinetic crisis on daily activities, including also sleep, and also in some cases they need emergency care because this can lead sometime to status dystonicus. So I think that this work was very important to better predict the dyskinetic crisis, and also to train caregivers to recognize this crisis. As I told you yesterday, after making the diagnosis of a GNAO1, I think that the second or third visit has to be to talk about what is a dyskinetic crisis, and also to talk about deep brain stimulation, because parents usually face the decision when they are in a emergency situation. So these are some graphics that is also in agreement with Erica's work, that usually seizure appear first in children with GNAO1, and then movement disorder, including this dyskinetic crisis. And you can see in the upper part here that this can appear up to the age of 8 years of age. Yesterday, I heard from some parent that his child started at the age of 11, so probably there are some cases that can start even later in life. And this is what I presented yesterday, something that it can contribute with the discussion between the parents and their physician is a guide about some aspect to know about the dyskinetic crisis, including, of course, the emergency care and all that. And as I told you yesterday, this is already translated in 5 languages. It will be soon available for all the GNAO1 community. This is the second part of the patient center, which is the DBS decision making. As I told you yesterday, this was a topic that was raised by a mother of a child of GNU from Italy, because she had a very hard time with the family when she had to decide for deep brain stimulation. So she thinks that this process can be improved, and I think it can be improved. So we analyze in this project all the factors that parents take into account for making this decision to undergo for deep brain stimulation. In this project, you can see there the survey. There was 12 parents that participate. The mean age of the patient was 14 years. The mean age of DBS was 10 years, and some of them has a follow-up of 12 years of being under deep brain stimulation treatment. You can see here that there was an excellent response in 8, and in 8 of these patients there was no response or minor response in the other patient. And you can see also here that this is what was the previous situation, and we plan to change this, that patients don't make this decision in the urgent setting. So the main facts that the caregiver highlighted was that there was communication gaps between when the physician explained about deep brain stimulation and when they finally get it. And so we think that using this, I will show you here, using this also a brochure or leaflet for patients, this can also help parents to communicate better with a physician and to see what are the questions they have to ask, not only regarding the procedure, but also here's the long-term impact on quality of life. Here's a scale. You can see that when it's nearly 5, that in the blue, gray, and the orange, and the dark blue, this is the aspect the parents usually take more into account when they make this decision making. So we can also use this information when we give information, we explain the procedure to parents. As I explained yesterday, this is the whole work is going to be published soon in the Neuromodulation journal. So after we have collected all this information we have on scale, we are now wrap up all the information to define this longitudinal phenotypic trajectory on GNAO1, because I talked with Merche, a mother of a child. They say we are under the umbrella of GNAO1, but each of our children are very different from each other. So if we want to go to personalized care, and I think it's going to be variant case care in the future, we have to understand better the disorder. So in this study, we combine prospective data from 21 of Spanish patients that participate in our Spanish natural history study with data we get from the validation project of our scale. We are going to validate we are going to do the validation of this scale with other countries not included on the European Union, and with patient included in the AGPRD natural history study. So we think that this is very important because we have data provided by physicians in 56 patients, so including the GNAO1 severity score. This can help us to define better the natural history and also to guide therapeutic timing, because we also see the difference between the approach we have to have with milder cases and with children with moderate or severe cases. So in this longitudinal trajectory, we compile information about the global disease severity, the movement disorder severity, epilepsy, motor function, adaptive functioning, the community communication and sociability, and also the daily life function and the quality of life. In this study, there are 4 novel variants between these more than 14 variants. And there are patients included from the age of 11 months to 21 years. And in the whole project, 4 patients have died due to complications related sometimes with this kinetic crisis and sometimes with infection. So this is the protocol we follow up for our Spanish natural history study that is very similar with some variation with the European. And we found that in this natural history study that in the whole cohort that movement disorder affect more than 90% of the children. Around 57 of they experience this kinetic crisis, and these kinetic crises are related to variants. So we already know that there are some variants that are not going to present this kinetic crisis. Epilepsy was in a 50%, more or less, about the percentage of ERICA. And most of these patients show drug resistance with epilepsy with diverse seizure types. And in this natural history study, we have a severity score that range from 0.5 to 13. I will show you some of these. And we have representation, but you can see that more than 2/3 of the patients are on the moderate and severe end of the phenotypes. So these are some. These are showing the frequency of the different. The main feature of the phenotype, the age of onset of the different epilepsy, movement disorder, and this kinetic crisis. And this is we are going to change because this graphic is a little messy, but it's going to show how different they are in each of these variants. We are happy that we can collect many patients with the same variant, proving that they almost behave in the same way. So in this study, we found that, and I will show you with a graphic, that global severity stay stable, meaning that patients that are in the male phenotype will remain mild, patients which are in the moderate phenotype will remain moderate, and patients which are in the severe phenotype will remain in the severe end of the spectrum. We only see some variation. I will show you some of these cases where there are some variation of the score related to a worsening of movement disorder. Also, that we are seeing that adaptive skills are improved in mild cases, meaning that we have to really help this child with the mild cases, with the rehabilitation has to be oriented in another way. And in case with severe phenotype, we show no change in these adaptive features. And something that is always in the room is this a neurodevelopmental disorder or is a neurodegenerative disorder. With the data we have with this 56 patients, we think that it's a non-degenerative disorder. Patient can die but it's of this kinetic crisis, but the course you will see in the graphic remains stable. So this is just to remind the GNAO1 severity score that is based on 5-pillar epilepsy, movement disorder, gross motor function, language, and feeding that is very easy to administer in the daily basis consultation. And you will see here each point represent one measure, and you can see here when they are when there is a line between two, it's the same patient, and you can see here that in red there is the mild phenotype, in green there is the moderate phenotype, and in blue is the severe phenotype. And you can see that after 4 years, the patient remained more or less in the same end of the spectrum. For example, this case, you will see here that almost go there. This patient has DBS in this part, and he has a worsen of dystonia related to DBS programming. But when this was reverted, he came back to the mild phenotype. You know, so sometimes there can be some fluctuation, but usually it's related to medication or some medical procedure. So in conclusion, for this part of the study, we showed that GNAO1 is a stable disease, but with worsening of movement disorder. And we found that these kinetic crises are present only in patients with moderate and severe phenotype, but not in patients with mild phenotype. That is also a good point to tell to the parents. And when they have children with mild phenotype, sometimes they are very worried about this kinetic crisis. So we also think that the severity score will aid in prognosis and also support this genotype or variant-based care, meaning personalized medicine, and that early intervention that is on movement disorder in severe cases could improve outcomes. Patients that are in the severe spectrum of the disease, we shouldn't wait too much to put on DBS or for the dyskinetic crisis, and I think that is going to be an improvement of care for this patient. So another part of the work we are doing is we have created a database on neuroimaging, and we are starting to identify some structural brain abnormalities in these patients. This is a work done by Christian Stefan Otto and Julia Romagosa. They are from the radiology service on the Hospital Sant Jan de Déu. So for this work, we collected, you can see here, we collected MRI of 35 patients, and we divide this MRI of what we can obtain before the age of 1, and between the 1 and 3 years, 4 and 7 years, and 8 and 15 years. We only have analyzed yet this from the 4 and 7 years, and we have to do now the longitudinal analysis of this patient. You can see here the severity score of this that is more or less representative with the natural history study, the type of mutation, all the variants that are included in the study. And what we interestingly find, but we have to do more work to see when this appear and when if this progress and if this severity and variant related, is in a preliminary volumetric finding. We have found that the entorhinal cortex and a part of the cerebellum that is called cerebellar crux X, it is reduced compared with typical developed children. This finding we found in 9 patients, and all of them have this when we analyze between this age. And also we are very confident because we found this that this decrease in volume is symmetrically. This you cannot observe by the simple examination of the MRI. Or you cannot look at the MRI and see this part is decreased. You need to do this volumetric specific analysis. So we are also, as I told you, we are trying to find some biomarkers. We understand that what we can see in blood is not what is happening in the brain, but as we cannot access to CSF all the time, we need some. We need to look if we can find some biomarkers on blood to predict the severity and also to monitor treatment as caffeine or zinc. So for this project that is funded by the Famiglie GNAO1 Italy, we need to collect 40 GNAO1 patient samples and 40 age and sex matched control. We are going to collect this from the hospital, and we are collecting, and we are collecting these 20 now, but we need help from all the researchers, because we also need to collect 20 samples from outside Spain. So if you are interested, you can, or the researcher here, if you are interested, we can provide the tube, and we can also collect the sample when you have collected at your hospital, and we need to do this to finish with this project. Sorry. We also are doing. We have developed this GNAO1 severity score, but now we have to validate and see is reliable, there is a agreement between observer, etc. So for this project, we have this protocol that we have to have 2 observers per center. They have to apply the GNAO1 severity score at day 1. The observer 1 have to repeat this process, can be by phone between the week 1 and 2, and also we have to repeat this at 1 year to see if there is a correlation between all these observations. So we are doing now. We are doing now. We are around this part with the non-European countries, and we are starting with the AGPRD natural history study to also do this validation process. So this is just a summary for parents that, as I showed you, we have studied a dyskinetic crisis. I think you all know what it is. We show the frequency, the lasting, and also how it can affect the daily life. For deep brain stimulation, we have explored what caregiver thinks about and how we, as a physician, should approach when we give the parent the information. We have tracked 56 patients with GNAO1, 21 prospectively over 4 years, showing that movement disorder worsen in severe cases, but mild cases can show an improvement of daily skills. And this severity score can help us to predict the outcome, and also I think in the future can help us to manage treatment with this patient. And this is just to finish. I want to thank the GNAO1 Spanish Association for all the support along the years and for really being there and participating. I also want to acknowledge Kirill Martemianov, because he performed all the functional study for our projects. Also, these are all the collaborators on the non-European part of the project. And also, I want to acknowledge Laura Sif, Carola Reinhardt, and Lucas Oliani, and Jane Yu for the DBS and dyskinetic crisis project.